important for normal chemistry result of CSF, or normal for not just for chemistry, for all the component and the function of blood of the CSF. So rate of formation is around 500 milliliter per day, and that's equal also to the rate of excretion, should be also 500 milliliter per day. So the formation will be occurred by selective ultrafiltration, and also there is a small amount with like 20% by active secretion by epithelial membrane. And excretion will be through arachnoid villi, go to the venous sinus of the brain and go back to the bloodstream. So to summarize this slide, so the CSF formed at the choroid plexus, and by either ultrafiltration or active secretion by epithelial membrane, and will be excreted through or absorbed through arachnoid villi to the venous sinus of the brain, and then after that will go back to the bloodstream. The rate of formation should be equal to the rate of excretion to have a constant CSF. So how we can get the sample of the CSF? It's by procedure, should be by skilled physician in the OR room, an operating room, I mean, and with aseptic technique, should be very sterile, to be what we call it lumbar puncture between L3, L4, or sometimes lower between L4 and L5. This is big according to the status of the patient. So after that, we'll separate it to different aliquot, that means tubes, like tube number 1, chemistry, serology, and microbiology, and some for culture, to study many things, to study cytology, study glucose and protein for chemistry, study type of the cells for serology, study in microbiology. Also, we'll do some culture to know it is bacterial meningitis, TB, or others. And we should do it immediately, because if we keep it for a long time, it will, first of all, will have glycolysis, so we cannot, we will have underestimate of glucose measurement. And also there is also some change in the cells as well. As a precious sample, usually we preserve it. So because it's very difficult to get this sample, so it's not like other blood samples or urine samples. Usually we keep it. We have here, like for example, in our hospital, we have a policy to keep these samples, normal samples for 6 months, abnormal for 1 year. So we have to keep it under -80. So because it's very precious, and we don't want to lose it if later on we need to go back to these samples. So what's the indication? One, the doctor will decide to do this very invasive procedure. If the patient suspected to have CNS infection, disseminating disease, malignancy, or hemorrhage. But also there are some contraindications, like if the patient has bleeding disorders, increased intracranial pressure, or infection at the site of needle. Like, let's go to the slide before here. If we have here any outside here there is an abscess or any skin infection, we don't go through to do lumbar puncture, because maybe it might also transfer all this infection from outside, from the skin, internally to the CSF as well. So the indication is infection, disseminating disease, malignancy, and hemorrhage, while contraindication, infection at the site of the needle insertion, increased intracranial pressure, or bleeding disorders, DSS or disorders. So after we extract the CSF, we have to put it in different tubes, diagnosing microcell count and cytology. So microscopic, that means physical. Microscopic, like by our eye, how we can examine the tube here. So usually we have to take the tube. It should have, like, if we have normal CSF, it will be like a water. And we put any paper behind that tube, we can read what's written there. It should be colorless, no any clear, no any aroma, no any clots, no any blood, like water. If we found by naked eye, if we found there is a cloudy or turbidity, that might indicate leukocytosis or erythrocytes. If it's like blood stained, like red color, either traumatic, we'll talk about it now, traumatic lumbar puncture or intracranial bleeding. There's a true bleeding here. Xanthochromia, which is important, I need today to concentrate on the traumatic LP and also xanthochromia. I will explain it now in detail, and this is important point here. Xanthochromia, presence of bilirubin or indicate older bleeding. Xanthochromia, usually the color is yellow. So either it's normal, which is colorless, or it has like it's whitish a little bit or turbid due to leukocytosis or leukocytes or erythrocytes, or it may be red, it's due to either traumatic or intracranial bleeding, or yellowish, which is most commonly due to xanthochromia, which is indicate older bleeding. So how we can differentiate between traumatic and what's the meaning of traumatic TAB and subarachnoid hemorrhage or xanthochromia. So at the beginning, let's go back to this figure here, or this illustration. So when the treating physician or the doctor will go inside here to get the CSF here, sometimes leads to some of the rupture of some of the vessels here, some veins. And so when it has some rupture, so in the needle here will get some blood from these veins. It's not necessary to be from CSF. Maybe CSF is clean, it's like a water, but you will get here in the syringe some blood. When the doctor will pull more, will start this blood to be a little bit lighter. And because when the air started to extract CSF. So here you call it a traumatic, but sometimes you need to differentiate between traumatic due to like something happened, not a real hemorrhage in CSF. CSF is intact. The color is colorless like water, while there's a rupture before we reach to the CSF. What we call it, this one, we call it traumatic TAB. Traumatic TAB. So, and you can see here, there's a bright red color. RBCs in decreasing number in the fluid it's sampled. And this is a traumatic here. I got it, I Googled it and I found it there. So it's at the beginning will be like a little bit red, then after that the other side will be a little bit lighter and then will be more light. With xanthochromia, it's all the bleeding. So usually we know when we have like bleeding, we have RBC, rupture of RBC will have hemoglobin, heme and globin. Heme will degrade the catabolism of hemoglobin of the heme will give me biliverdin, which is the green color, and then bilirubin, which is the yellowish color. So xanthochromia, when we have at least 2 hours of bleeding or RBC slices before. So this is the xanthochromia, which is here what we're talking about. Here, this is the one, and this is the normal one, as I can see, and this is here real hemorrhage. So subarachnoid hemorrhage, what we call it xanthochromia, which is yellowish pigment due to RBC lysis and metabolism at least 2 hours before, while traumatic TAB is something that happened due to rupture of the vein, and will start to the color of the red color will start to decrease when when the doctor will start to take more CSF to reach deep more. So this is her from microscopic. Let's summarize microscopic. So either normal or cloudy, which is here started to talk about something. This is a normal one. It will be colorless, clear, free of blood. Cloudy due to leukocytes, stained by blood, either traumatic or real bleeding, intracranial bleeding. Xanthochromia will be yellowish due to indicate older bleeding. So we have like 1, 2, 3, 4 categories. And we go to differentiate between traumatic and SAH with subarachnoid hemorrhage. The other also name is xanthochromia. Now we'll talk about, this is, we call it macroscopic, like physical, and some cases we call it physical. And now we'll start talking about biochemical examination, which is today we'll concentrate on biochemical, and there's also microbiology I think will be covered by microbiology, and there is also cytology. But I will touch it a little bit for just to complete the picture of the meningitis here. So we usually we measure in the biochemistry lab glucose and the protein. In microbiology, they measure maybe they will do cultures, and also they will count the cells, and they will differentiate between, especially in cytology, like lymphocytes. So need here 3-4 labs just to have it: hematology, cytology, microbiology for culture, and chemistry for glucose and protein. Cytology to count because we have qualitative and quantitative of the to study the types of the cells. Also, we have also microbiology to do some cultures. So we in chemistry lab we study glucose, protein, and then we need also, if a protein is also here, protein is high, we need to also to study more the subtypes of the protein like albumin, immunoglobulin as well. And also sometimes now it's not too much often to study lactate, but still some of the labs they still measure lactate. So let's start with the glucose. So glucose usually enter the CSF via facilitative transport because the glucose transporter. With CSF glucose concentration is 2/3 than of the blood. Like it will be less than, so the glucose concentration in the CSF will be less than the glucose concentration in the blood by 2/3. So it is between 50 to 80 milligram per deciliter. Plasma sample or blood sample must be obtained because usually we take the sample for the patient for blood to do a lot of testing, like different analysis, and after that also we take the CSF as well through traumatic, through lumbar puncture. So usually because we, as I mentioned, so CSF concentration will be like reflection of the blood because it comes from the blood. So if we have hypoglycemia, so ultimately CSF also in the glucose will be low, while also hyperglycemia CSF will be high. Because it's usually the glucose in the CSF will be part of the blood glucose, but it's through facilitative transport across the blood-brain barrier to reach to the CNS. So measure usually after we extract the blood, taking the the CSF, we have to measure it immediately, and we have to put it also in tube. This is technical things, but I need you just to know about it. To keep it and preserve anticoagulantic, we anti-glycolytic sample, which is usually we call it a gray top tube because it has a fluoride, and that fluoride will prevent the glycolysis, so we can measure the glucose accurately. That's why we need to measure it immediately, and also we need to preserve it in what we call the gray top of fluoride tube. That tube has fluoride to prevent the glycolysis, or we call it by any substances, we call it anti-glycolytic substances. So here from this slide we know, so the glucose will be 2/3 of glucose concentration will be 2/3 of the glucose in the blood, and will enter through facilitative transport. Well, I mentioned that many times because we will see now with some abnormality, there is importance of this glucose transporter. So if we have glucose high, so it's not any clinical information because usually we in the lab here we think always about low glucose in CSF. So low glucose in CSF either due to disorders of carrier-mediated transport, which I'll talk about it now. So sometimes in the TB, meningitis, or sarcoidosis here, the glucose transport will be affected, and so we'll have less glucose. So we'll prevent that when we have problem in the cardiac-mediated transport, so we'll not have that transportation of the glucose from the blood through the blood-brain barrier to the CSF, so we'll have low glucose. And this happens in the case of TB, meningitis, or sarcoidosis. Other also cases, or another case scenario here, when we have sometimes acute bacterial meningitis, amoebic meningitis, or fungal meningitis. And here, what will the mechanism here? There is active metabolism. There is like the amoebic, the fungal, taking this, utilizing this glucose, utilizing this fuel, will be taken by the cells or organisms. So this organism will use, like for example, the fungal or amoebic or bacterial will use this glucose as part of their food or the nutrients, and that will lead to decrease the glucose in the CSF. Another also example here, increase the metabolism by not by something like organism like comes from outside, but came from outside, but by CNS itself when we have cancer, neoplasm. So we know when we have cancer, so the cells will be more, and this cells will have a lot of cells rather than the normal CNS cells. That here also will have increase the metabolism of the glucose, and increase the consumption of the glucose. In viral meningitis, the glucose will be normal. So let's summarize again or review again why when we have low glucose concentration in CSF, either due to carrier-mediated transport disorders like in TB meningitis, or increase the consumption of the glucose by organisms like in bacterial, amoebic, or fungal, increase the catabolism or also consumption of the glucose by CNS cells itself or themselves due to CNS tumor. So either by TB meningitis, bacterial, amoebic, or tumor, all of them will have low glucose, while viral will be normal. And this is part of how to differentiate between viral and another type of meningitis. So this is here regarding the glucose. So let's move to the protein. Protein, it's the opposite. Usually we look for high protein. So at the beginning, we know we have the protein has albumin and also immunoglobulin. Usually in the CSF, usually we have more, like blood, always we have more albumin rather than immunoglobulin. So 80% of the protein comes by ultrafiltration by albumin. Mainly it's albumin by because albumin is small, so can go through blood-brain barrier. While 20% it was mainly it's immunoglobulin, because immunoglobulin is usually it's big, so it will be synthesized locally in the CNS. We call it intrathecal synthesis. So 80% is mainly albumin, 20% is mainly immunoglobulin, which is due to internal or local synthesis of this immunoglobulin. So CSF here the opposite. Usually when it's a glucose low, usually the protein will be high, and this is always the situation. So at the beginning, maybe we can compare it with the serum protein as usual, like always. Also for glucose, when we measure the glucose in the blood, we measure it also in the CSF, we measure it in the blood. The same thing here, when we measure it in the CSF, we measure it on the blood as well. So useful non-specific indicator of pathogenic status. At the beginning, it's due to, first of all, we have to rule out traumatic tab, usually because of any lysis of the blood cells, it leads to increase because all the cell membrane is protein. So when we have high, more ruptures of blood cells, and may have more protein in the CSF. So first of all, we have to rule out the traumatic tab. And now we'll talk about something is like real increase of the protein. For example, here, increase the permeability of epithelial membrane due to bacterial or fungal infection or cerebral hemorrhage. In cerebral hemorrhage or bacterial infection or fungal infection, the epithelial membrane will increase the permeability and allow more of the protein to go out. Also increase the production of the, increase the production of by CNS tissue as well, like multiple sclerosis, and we'll talk about it now, or subacute sclerosing by encephalopathy, we call it SSPE, or obstruction due to tumor or abscess. So now you have, like, if you have a high product in the CSF, either increase something entering more, or there is obstacle to allow it to be excreted, or something there is local synthesis. So we have three different technique or mechanisms increase the entrance of protein to the CSF due to increase the permeability of epithelial membrane, like in bacterial or fungal infection or cerebral hemorrhage, or there is a local synthesis like in multiple sclerosis, and talk about it now in details, or what we call it, also this is another autoimmune disease, we call it subacute sclerosing encephalitis. Usually it's more common than multiple sclerosis, or there is something to prevent this protein to go out like tumors or abscess. So there are three mechanisms. Permeability more, like TB meningitis or bacterial meningitis, more, which is the most important one, is MS, multiple sclerosis, local synthesis, or some obstacles here. Let's talk about the most important one here, or like most famous multiple sclerosis here. So at the beginning, IgG either will come from plasma cells, come within CSF, or from the blood. Either there is local synthesis or comes through blood-brain barrier from the blood. When we have IgG high, while normal albumin, as here we talk about at the beginning, like 80% mainly albumin because it's small molecule, and 20% from immunoglobulin. So here when we have immunoglobulin, IgG is high while albumin is low, or normal, not low, normal. So we know, so it is not through ultrafiltration, there is local synthesis because now the IgG is high immunoglobulin while the plasma is normal. So not this protein didn't come through blood-brain barrier by blood. This is something we like local synthesis. So from here we can know, this one we have IgG high. This is what we do in the lab. At the beginning, we study the protein in general. If we found this protein high, we start to study the subtypes of protein, albumin and immunoglobulin. If we found the albumin, so protein are already high, but this protein is high due to albumin or due to immunoglobulin. If we found the albumin is normal while a protein is high due to immunoglobulin, that means there is a local production, and mainly it's multiple sclerosis. If not, we have to study or consider subacute sclerosing encephalitis, which is usually less frequent or less common than MS, which is MS usually is the most important one. You got it? So we have protein high. So we do subtypes, or we can do sub-measurement of the albumin and the protein. If albumin normal and immunoglobulin high, so protein high due to immunoglobulin, that means there is local synthesis and it's mainly multiple sclerosis. How we study it in the lab, I don't want you to know all the details, but just I want you to mention it to you quickly. We do something we call it after measurement by mass, like after measurement in the ordinary machines, we do something furtherly, we call electrophoresis, to know the type of separation, and what do we call it here? This is usually by electrophoresis. I don't need you, just this is for your information. No need to study too much. This is postgraduate mainly. So electrophoresis is a technique to separate the type of protein, like pre-albumin, albumin, alpha 1, alpha 2, beta 1, beta 2, and gamma. This is usually the normal diagram for that. This is the normal pattern. And multiple sclerosis, this is how to confirm it by, this is neurology always reading this one because they need to confirm multiple sclerosis for this patient. So when this patient got this oligo, that means between 3 and 12, this is oligo. 2 like di, more than 12, we call it poly. So oligoclonal band here, which is like 3 and above. So we have here, like, for example, 3 hubs or 3 peaks here in gamma region, and usually it will be the report. So there is oligoclonal band in the gamma region of the electrophoresis, protein electrophoresis of the CSF that suggested to have multiple sclerosis. So usually this is how to confirm multiple sclerosis. So we measure at the beginning protein in the blood, protein in the CSF, we found it high. We go to measure protein and immunoglobulin. We found immunoglobulin high. We go for electrophoresis to separate it. If we found this oligoclonal band, we confirm to the treating physician, which is usually neurologist, this patient has multiple sclerosis. And this is what we usually write in the report. So there is an oligoclonal band in gamma region because we call it this gamma region. Did you see the normal one? This we call it gamma. Usually it should be like that. When it's here, you can see here, it's not like that. It's not one peak like here. It's 3 peak. And that's why we say there is oligoclonal band in gamma region and CSF protein electrophoresis that suggested to have multiple sclerosis. This is for your information. And this is how we diagnose multiple sclerosis. So let's quickly summarize the protein protein CSF from the beginning. So protein usually is mainly albumin, 80%, 20% come from blood by ultrafiltration, 20% in local synthesis, mainly immunoglobulin. You will find protein is high, either due to increased permeability of epithelial repair. The most important example is bacterial or fungal infection, increase the production, also due to multiple sclerosis, local synthesis, or there is obstruction. The example here we took it is when IgG is normal, where IgG is high, albumin is normal, so it's mainly multiple sclerosis, and we studied the pattern by electrophoresis as well. Now we'll go to lactate, which is the lactate usually is not so much like common nowadays, but you need to know it as well. So lactate, you studied maybe when we studied the anaerobic breakdown of the glucose, so originate from glucose. Anaerobically important for distinguish between viral versus bacterial meningitis. So lactate will be high in bacterial meningitis and disorders of blood supply. Sometimes if we have hypoxia, because usually it will be increased in anaerobic condition in the absence of oxygen. So it will be increased by hypoxia, stroke, or the subarachnoid bleeding as well. So other also chemical component like calcium, phosphate, and potassium, usually they are lower than, they will be low, the concentration will be in the CSF lower than their levels in the blood. Chloride chloride in the CSF and magnesium will be higher in the CSF rather than in the blood. Usually we study just the chloride. Chloride is the most important one. Usually we measure in the CSF the chloride concentration. And markedly will be decreased in acute bacterial meningitis, where will be normal or slightly low in viral meningitis and the brain tumor. So usually we measure chloride. So chloride normally is higher. The concentration of chloride is higher in the CSF if we compare it with the in the blood. It will be decreased in bacterial meningitis and will be slightly decreased or will be normal in viral meningitis. This is the most important, is a chloride. So now I will move, this is all for chemistry. So talk about the glucose, protein, and lactate. Now we'll go for cytology, and I will not talk about it too much because it's mainly it should be covered by either cytology or microbiology team usually. So, but we need to touch it a little bit to have comprehensive report for the patient with meningitis. So usually in the CSF we'll have lymphocyte mainly and a small amount of monocyte. Abnormal cells can be RBCs due to traumatic TAP, sarcoid hemorrhage, neutrophil, but due to bacterial meningitis, lymphocyte predominance in the viral and TB and chronic inflammation. Also, plasma cells, activated lymphocyte in chronic inflammatory diseases, and multiple sclerosis or tumor cells. So normally, if we go for microscopic examination, we will find lymphocyte mainly and monocyte. If we find RBCs, we have to think about either traumatic TAP or subarachnoid hemorrhage, true hemorrhage. Neutrophil neutrophil is important because we will see it now in the cases of bacterial meningitis. Lymphocyte, maybe it's viral or TB or chronic inflammation. Plasma cells, chronic inflammatory disease like MS, or malignant cells like tumor cells in CNS malignancy. So here, like a summary, so how we can, so by cell type, neutrophil, it's more bacterial, lymphocytes is more viral or TB, RBC is more hemorrhage, malignant cells is more like, it's absolutely, it's cancer. This is like a table to summarize all the type of, but I don't want you to memorize it. This is like, usually we will say, okay, we have protein high, glucose low, or vice versa, but it's not, no need to know numbers here. Just to know chloride usually higher in the CSF, more than will be in the blood, and glucose 2/3 of blood concentration in the CSF, more than in the 2/3, less than in the blood, I mean. So this is a summary of what we talk about it. So as in terms of like appearance, when it is in bacterial, it will be turbid or cloudy. WBC will be high as a neutrophil, protein will be high, glucose will be low due to consumption of the glucose. Lactate will be high also, and chloride will be normal or low. Mainly it will be low. In tuberculosis will be cloudy. There is a fibrin web. Lymphocyte will be not neutrophil lymphocyte. Protein will be very high. Glucose will be very low. Lactate will be high, and chloride will be low. Viral will be clear. No any turbidity. No any fibrin web. Usually lymphocyte we have mild protein, and just sometimes it's normal glucose, normal lactate, and normal chloride. Usually viral always it is normal, except sometimes like we have more, a little bit mild protein, but usually not too much, and we have some high lymphocytes. So let's just study some cases here, just to summarize what we talk about. So if we have like a male with 25 years old, present with fever, headache, neck stiffness, and altered mental status, and we found the CSF by microscopic examination is turbid. Cytological examination, we have high neutrophil, chemistry examination, chemistry analysis, we call it low glucose and high protein. So what we can suggest it here, so high neutrophil, low glucose, high protein, it's mainly bacterial meningitis. The other case here, 20 years old female, complaint of headache, mild fever, no altered consciousness. So it's clear when, by microscopic physical examination, lymphocyte, normal glucose, mildly elevated protein. It's mainly, it will be like viral meningitis. In case here, third case is 40 years old male with chronic headache, weight loss, night sweats, slightly quiet, cloudy is a CSF, lymphocytes, here is high, lymphocytosis, very high protein, very low glucose. So it's mainly because, why we said it's chronic, because usually tuberculosis will take long time. And night sweats, no, this is type of clinical features of the TB. So here is TB meningitis. So as a take-home message, so CSF is produced by choroid plexus and maintain a stable CNS environment. CSF provides protection, nutrition, and waste removal for the brain. Any abnormal CSF finding leads to potential CNS pathology. So we have to study microscopic biochemistry and cytology, and we have to differentiate between different patterns. Hopefully it was like very, let's say, very straightforward message to you. And if you have any question, please let me know.
Thank you. الله يعطيك العافية دكتورة.
Is it clear? I try to make it very simple. So it's a question, like let's talk about the exam. So the question will be very like cases, and I don't want you to know number. I don't want you to know to memorize numbers. Just to know something basic, like for example, 80% of protein is through by ultrafiltration, which is mainly albumin, 20% immunoglobulin. The glucose concentration in CSF is around two-thirds, like 80% or 70% of in the blood. This is the only numbers I needed. But I don't want you to know, memorize more. Chloride more like, this is like part of the question exam questions. Chloride will be in CSF more than in the blood. And when we have like, this is some case scenario or MCQs will be the same. Like when the glucose is, for example, low, protein is high, chloride is low. So you need to tell me lactate low. So give me like, I will put viral, multiple sclerosis, whatever, and we will choose, for example, bacterial meningitis. So here it will be, but I don't want you to know numbers. Electrophoresis, just to know oligoclonal band in MS. But no need to study electrophoresis, no need to know the pattern, no need to draw the pattern at all. This is just example to show you how we usually diagnose multiple sclerosis, which is something very common usually in the clinical side. When you go to the clinical, the hospital, you will see it within neurology or autoimmune disease as well. Everything is clear. If you have any question, please let me know now or anytime. You have my number, you have my email, so don't hesitate. I can repeat also the lecture if you don't, if you have any question as well, or if we can have like some cases as well. Clear?
Clear. الله يعطيك العافية دكتورة.
الله
ما
يعافيكم يا
قصرتي.
رب،
Thank you so
يعطيكم
much.
العافية. شكرا. Have a good day. Bye
You
bye.
have a good day too.
Bye bye. مع السلامة.